Our next panel is on the criminal justice system in Medicaid, collaboration or collision post-healthcare reform. Again, those of you in the back, if you could please find seats. This panel is being moderated by Dr. Stephen Summers. He is the President and Chief Executive Officer of the Center for Healthcare Strategies. They're located in Princeton, New Jersey, and he founded that in 1995 with a major grant from the Robert Wood Johnson Foundation, where he was previously an Associate Vice President and Program Officer. Prior to that, he was a professional staff member at the U.S. Senate Special Committee on Aging and in L.A. to Senator John Hines of Pennsylvania. Dr. Summers also serves as a visiting lecturer at Princeton University's Woodrow Wilson School of Public and International Affairs, and he earned his Ph.D. in the politics of education from Stanford. Steve.
Thank you, and good morning as well. And I would like to do one housekeeping task, which is to remind you that these little blue cards in your book are for handing in questions and, if you don't want to be searching a microphone. So this is an option for you. In terms of continuity from the last session, I don't know if Tim was still here, but I was reflecting when he opened his comments about the fact that I'm from Princeton, New Jersey, and I was in D.C. last night, so didn't have the chance to ask my wife about her wildest dreams. And it's a good thing, because I'd feel a lot like Tim at this moment, probably. So wanted to establish that as one thing, and then also in looking at the title for this session, I noticed right away that it had the word collision in it, and I just back-ended somebody, so I was a little sensitive about the word collision. And I know there's also collaboration in here, so it's collaboration and collision, or collision, with respect to the criminal justice system and Medicaid. I prefer to see this as an intersection. There was a lot of conversation earlier about the range of people that are attending this meeting, and it really is impressive, and I want to commend everybody involved in putting the meeting together, particularly Steve Rosenberg and Cochs, because it's rare that you get the opportunity to talk across these sectors the way we're going to talk about it here. And the objective is to create more and more momentum for a seamless meeting of the minds on these systems rather than collisions. And we have a group of people here, panelists, that are going to present some road signs for you, some caution flags, and some reasons for some longer-term optimism about the road conditions in this intersection that we're about to engage in. So without much further ado, I would like to introduce my colleague, Allison Hamblin, who has been working on programs at the Center for Healthcare Strategies that focus on the needs of complex populations, people with multiple chronic conditions who typically have both physical health and behavioral health issues, in addition to their intersections, as we're learning, with the criminal justice system. I mean, it was no surprise to her that there was an issue here, an intersection here, but I think it's fair to say that from the Medicaid perspective, which is where we work mostly, the scope of the intersection is a bit of a surprise, really eye-opening. So we're very, very privileged to be part of this, and Allison's going to present some results from a quick paper that we did, and then we're going to ask questions of the rest of the panel, and I'm going to introduce them when that opportunity arises. So, Allison, to you.
Do I do this? I do that. Am I going the wrong way? There we go. Okay. Well, good morning, good afternoon, everyone. My name is Allison Hamblin. I'm with the Center for Healthcare Strategies, as Steve mentioned, and it's a true pleasure to be here today among this group. And particularly want to take the chance to thank Steve and my co-authors on our paper, who we are representing. It was our privilege to try and represent the Medicaid voice in this discussion as these papers were developed over the last few months, and to help coalesce a group of Medicaid representatives for this meeting, some of which are represented here on the panel, and others of whom are represented in the room. And I think we have a great representation of some of the most innovative thinkers in Medicaid here with us today. So I want to thank those of you who are here for joining in the discussion. The purpose of our paper was to describe the subset of the Medicaid expansion population that is likely to have jail involvement, and as Steve mentioned, to shine a light on that for folks in the Medicaid world who may not be thinking about issues related to criminal justice as a core part of their plans for expansion. We also sought to make recommendations for Medicaid policymakers with respect to delivery system design in light of the populations that will have jail involvement coming in 2014, and also to discuss opportunities for collaboration and specifically to look at a potential business case that could support conversations and partnerships across systems at state, local, and national levels. Hopefully many of you have had a chance to read the paper, and so I will assume that you have. So here I will strive just to highlight some of the key findings. Others have discussed, in particular, the expected high prevalence of mental illness and substance abuse among the jail-involved subset of the Medicaid expansion population. I'll just say that that information was very much corroborated in the data that we looked at, which was based largely on states that have opted to expand coverage to low-income childless adults in the past, either through waivers or through other state-only funded programs. And in particular, largely building off the work of my colleague David Mancuso from the state of Washington, we've found one relevant number to look at in terms of what is the expected overlap between the criminal justice population, namely the jail population, and the expansion population. And in the Washington experience, and I'll let David elaborate on this when he makes his remarks in a moment, we can reasonably expect that potentially more than a third of the population, of the Medicaid expansion population, will have jail involvement, based on the Washington experience. Not many states have the ability that Washington has to track jail involvement among, in line with Medicaid service utilization. And one of the points I'll come back to in my reports is the value of data integration and the ability to look at individuals and their use of services across systems, and that being a really powerful lever to motivate cross-system collaboration and a real enabler of the work that David and his colleagues have been able to do in Washington. Turning to the recommendations that we considered for delivery system design coming in 2014 included the likelihood that states are going to contract with managed care organizations to deliver benefits for substantial segments of the expansion population, provide a lot of opportunities to use contracting requirements and purchasing leverage to drive a lot of the elements of the system that we would like to see and that we think are important for effectively serving populations, particularly with high rates of mental illness and substance abuse. So in particular, we will encourage states to contract with managed care organizations to the extent that they're pursuing a managed care delivery model that have relevant experience serving populations with these types of comorbidities and behavioral health needs. There are managed care organizations that do this really well and some that don't have as much experience serving these types of complex populations, and so that will be an important consideration for states. Continuity of care has been discussed. That will be a big issue, both in terms of providing continuity of benefit coverage for folks whose incomes are fluctuating and they're going back and forth from the exchange to Medicaid coverage and so forth. States are focusing on that issue a lot right now, and there will be a lot debated and decided in the years ahead as to the best way to ensure that that continuity is provided. One mechanism, for example, may be requiring that health plans that contract to participate in the exchange also participate in Medicaid and vice versa. And those types of continuity of care considerations and provisions will also be key for securing continuity of care around eligibility transitions upon release from jail, upon re-enrollment in Medicaid, and so forth. A clear recommendation is the need to include broad mental health and substance abuse benefit coverage. I was really happy for the point made earlier in the last discussion around the fact that we shouldn't assume that the breadth of those benefits are going to be there, and there needs to be active conversation and discussion on why certain benefits will be cost-effective, evidence-based, and relevant for certain subsets of the population. A key point in the paper and a key fallout from the discussion is the need for substantial investment in substance abuse treatment capacity. Medicaid plays a huge role in funding the provision of mental health and substance abuse services currently, funding more than a quarter of all services in the country. And obviously with expansion, the role for Medicaid in this area is going to increase. So together with block grants, Medicaid is going to continue to be an important source of funding for expansion. And given what we've seen in past state experience, it takes time to build treatment capacity. Even when you expand coverage and expand benefits, it takes a number of years for the requisite treatment capacity to develop. So all the better that we're having conversations like this today, and they need to continue in order to kick off those efforts. Another thing to mention on that front is that the ACA provides a lot of really important opportunities to support these types of investments. There are provisions that, some getting more attention than others, that could really support efforts like this to promote efforts to integrate and coordinate care, particularly across physical and behavioral health domains. These include health homes for people with chronic conditions, for which there's enhanced federal funding support, which may be particularly attractive to states. There's opportunities for grant funding of community health teams. There's opportunities to support co-location of physical and behavioral health professionals, which could dramatically improve, again, treatment capacity for mental illness and substance abuse. There's a number of key workforce development provisions, and there's the new Center for Medicare and Medicaid Innovation, which includes in its priorities the promotion of more integrated care and coordinated care, and may be particularly interested in efforts to better serve and provide care for complex populations like those and those individuals we are talking about today. That said, given the current budget climate and political climate, I think that we would all be well advised to not think of all of these opportunities as set in stone. These are moving targets, but good for us to keep on our radar, particularly as we think about mechanisms and levers to drive the changes that we all think are so well worth it. Finally, in terms of delivery system recommendations, we at the Center for Healthcare Strategies work very closely with states to help them be as effective purchasers of healthcare services as possible. Many states do a really good job of this, using contracting standards and payment and other policy levers to drive desired levels of integration, of quality, and performance among their health plans and participating providers. And given the opportunity under Medicaid expansion, there's a real opportunity here for Medicaid to use those levers to drive improvements in quality of care for jail-involved populations. We run through a whole list of contract provisions and performance requirements that could further those goals in our paper, and I won't spend a lot of time going through all of them here. But it's common for states to require comprehensive early assessments, to require care coordination, to require electronic exchange of information, to support medical home and other integrated healthcare homes, use of evidence-based practices, and to require quality and performance monitoring. And these efforts are accelerating under ACA with additional funding supporting them, and again can be used as effective policy mechanisms for driving the desired improvements in care for newly covered populations. The last topic that I want to mention, and part of our paper worth highlighting, is the rationale for collaboration between Medicaid and criminal justice system partners, as well as the provider community. I will leave it to my colleague, again from Washington, David Mancuso, to talk more about specific data in Washington that we really relied on to help make this case on our paper. But I think I would leave it to say that there is a case to be made that particularly expansion of substance abuse treatment capacity pays for itself, both for Medicaid and for criminal justice stakeholders. And by using these types of evidence and data from prior analyses, hopefully conversations across these system partners can be kickstarted. And I would just say that I think the conversations, particularly with Medicaid, should center on what problems collaboration across systems could solve for the various parties involved. And I think one of the things that's been really hitting home for me through discussions last night, this morning, and throughout the day so far, is that the jails really do present an opportunity to solve an important problem for Medicaid. And that namely is states are highly motivated to find, enroll, and assess beneficiaries who represent high risk for future costs and future utilization. This is a population that is of high priority to states across the country to find them, to locate them, to engage them, to enroll them, and to provide them with effective care management and care coordination that can prevent the most costly episodes of care down the road. And so to the extent that we can think of the criminal justice system and jail partners as facilitating that location and identification, the enrollment, engagement, and assessment of needs, I think that's a truly compelling opportunity that states will be anxious to engage in discussion on. So with that, I will turn it back to Steve.